Very good afternoon, everybody. I think we'll start this afternoon session. I would like to thank the organizers for inviting me for being in Buenos Aires. And as some of you may know, one of the topics I'm very interested in the last couple of years is fontan circulation. And indeed, I would like to share some ideas which did evolve enormously, I think, the last couple of years. For this presentation, I must say that I have no disclosures except for the fact that I do have a biventricular heart. And what that means, it means a lot. Before we will try to understand what are the limitations of a single ventricle or a fontan circulation, we have to understand exactly what are the advantages of a biventricular circulation. Here you have a cartoon representing a biventricular circulation. So we have two ventricles, the left ventricle over here, the right ventricle over there. And so the left ventricle will take the blood, take it from the left atrium, pump it into the aorta, keep that energy and dissipate that energy in the systemic vascular resistance while it will be losing its oxygen. All the blood will be recollected in the right atrium, where the right ventricle then will pump it into the pulmonary artery. It will add much less energy than the left ventricle, but some, and that energy is then dissipated in the pulmonary vascular resistance. Key features of this circulation is that at rest, by definition, you will have a cardiac output of 100% of normal, and a normal person can increase his cardiac output at maximal exercise a fivefold, so he can go up to 500% of normal. The right atrial pressure typically will be lower than the left atrial pressure. Normally you will have pulsatility over here and the patient will be fully saturated. Not everybody has the advantage of being born with a biventricular heart. Here you see some examples of single ventricle. Here a typical tricuspid atresia with a hypoplastic right ventricle. Here an unbalanced AVSD with a very small left-sided ventricle. A double inlet left ventricle with a small subaortic right ventricle, or a typical hypoplastic left heart. Some of you are adult cardiologists and then not very much acquainted with what needs to be done with these children very early in life in order to get to the fontan circulation. Here I will just represent what can be done in these patients. For instance, the patient with tricuspid atresia. In the neonatal period, in order to get rid of cyanosis, we can stent the duct or we can give him a shunt, in this case a Blalock-Taussig shunt, and then we get such a circulation. The main differences with this circulation is that we only have one ventricle, the single ventricle, who will take the blood from the atrium, pump it into the aorta, and from the aorta, both circuits, the systemic vascular resistance and the pulmonary vascular resistance, are connected in parallel. So in other words, that single ventricle has to provide the blood flow for both systems. In order to get somewhat a reasonable saturation over here, by definition, the pulmonary flow must be bigger than the systemic flow. So if you look at the limitations of this circulation, this ventricle at rest will do much more than the normal ventricle, typically 200 to 300% of normal at rest. And that ventricle will be able to increase somewhat its output. You will have a QPQS, typically more than 1, but all these patients will be desaturated. This means that the ventricle will be chronically overloaded. There will be a component of overgrowth and dilation. And the pulmonary arteries, I mean, either they will be too small or they may have some degree of pulmonary vascular disease. In the long run, this was very bad. We know that these patients could not survive such a circulation for more than 3, at most 4 decades. They all would die. So then came the invention of the fontan circulation. It was first done about 40 years ago. And what was the key feature of the fontan? Well, both circulations, so here the systemic vascular resistance and the pulmonary vascular resistance, are put in series the way it should have been, but only with one engine, only one pump. So in this circuit, the ventricle will take blood from the atrium, pump it into the aorta, and the energy, instead of losing it all into the systemic veins, no, the energy is collected in the caval veins. Caval veins are connected to the pulmonary artery, and then this energy should suffice for the blood to go through the pulmonary vasculature. What are the typical features of such a circulation? At rest, the output always will be smaller than normal, let's say about 70%, and those patients can increase their output somewhat, but definitely not as normal. The systemic venous pressure in the caval veins will be much higher than normal and much higher than what is used to be seen in the left atrium. With this connection, and it's the current type of connection, there will be no pulsatility, and depending on whether there is a fenestration in these patients, they will be fully or not fully saturated. But so the key feature in this circulation is that the surgeon did create a portal dam over here, and this dam is first of all responsible for the congestion, which means the increased pressure in the caval veins, and second for the decreased output, because the flow through the lungs over here will not be as efficient as you would see in a normal circulation. Again, for the adult cardiologists, how do we get to such a circulation? Well, in the patient I already mentioned with the tricuspid atresia, so in the neonatal period he would get either a stent or a shunt. Around the age of 4 to 6 months, we would do a bidirectional Glenn, which means we connect the superior caval vein to the pulmonary arteries to go then to a full fontan where the inferior caval vein is connected through a conduit with the pulmonary arteries. There are a lot of varieties on this circulation. Here you see it in real life where an angiogram of the right caval vein is connected to the right pulmonary artery, and here the inferior caval vein through an extracardiac conduit is being connected to the rest of the pulmonary vasculature. As I said, many varieties on this scheme. In this patient, for instance, we would go for initial banding to protect the lungs, then go to the Glenn, and here go to the fontan. So the final objective is always to connect superior caval vein and inferior caval vein to the lungs and actually bypass completely the lungs. A similar thing for a double inlet ventricle, where in typically 2 steps or 2 or 3 steps you would reach the fontan circuit, and also for a hypoplastic left heart, a similar scheme. I will not embarrass you with the technical details. The key feature is, how does this circulation function? Because obviously you can understand that there will be a lot of limitations to this circulation. Again, how does a normal person function? How does a normal heart function? Here you see a cartoon of cardiac output if this is exercise level with maximal exercise, and here's output. So normal, a person will have 100% of output at rest, and with exercise he will be able to increase his output to a maximum of about 500%. Where are our fontans? Well, the best fontan that we have will have a cardiac output at rest slightly less than normal, and yes, he will be able to increase his output with exercise, but first of all, he will not be able to do the exercise level that normals can do, and second, at a comparable degree of exercise, he will have a lower output. And that's something we experience in all our fontans. They can exercise, but at a much lower output. This, however, is our best fontan. This is the graph of our worst fontan, where at rest, cardiac output is significantly reduced, and these patients, if can do little exercise and hardly will be able to improve or increase their output. In other words, this means that all our fontan patients are in between these 2 lines. What do we need for this circulation to function? Well, first of all, there are a few cardiac requirements. In the second slide, I will show you that there is quite a few extra cardiac requirements, And at the end of the talk, I would like you to be convinced that the extra cardiac requirements are probably much more important than the cardiac requirements. What are the cardiac ones? Well, first of all, we want to have an unobstructed inflow. So in other words, no mitral stenosis, no mitral regurgitation, nothing like that. We want to have a reasonable ventricular function. I'll come back to that. So I clearly didn't say a perfect function, but reasonable function. And we don't want to have anything bad at the outflow. So no sub-AS, no aortic stenosis, no coarctation whatsoever. But much more important is the NIÑO portal system. First of all, we want the surgeon to make a nice and non-restrictive connection between the caval veins and the pulmonary arteries. And there we must say that the surgeons have been doing a very good job. Nowadays, they can make with the TCPC a connection with no turbulence, no energy dissipation, and almost no energy loss. Very important is that we have very good pulmonary arteries, which means all the segments must be there. Nothing should be hypoplastic. We don't want to see distortion. We don't want to see collateral flow, and the resistance must be as low as possible. And obviously the blood must be able to return to the heart without any obstruction on the pulmonary veins. However, very frequently we do see what you can call excessive damming, which means that because of creation of this system, there will be low output because everything has to go through lungs without a pump. There will be congestion with all the problems you can read over here, which we all know in the fontaines, and there may be also some residual cyanosis. If we don't like what the surgeon has been doing, or if we don't like the final result, we have the possibility to undo what the surgeon did. We can take down partially the fontaine circulation. We call it a fenestration. And actually, probably this is the most important slide of the whole presentation. It represents what happens if you go from Glen to fontaine. If here, with this line, if this represents what happens to the output, if you go from a Glen situation to the fontaine situation, in the very best patient, output will slightly decrease. In the worst patient, output will significantly decrease to levels which are probably not acceptable for any patient. What will happen to saturation? Well, in all patients, both in the best and in the worst fontaine patient, saturation will significantly increase. That's the good part of the circulation. However, what will happen to systemic venous pressure? Well, in the good fontaine, you will have the circuit at a mildly elevated systemic venous pressure. In the bad fontaine, caval vein pressure will go to very, very high levels, which are, once you go above 18 millimeters of mercury, is no longer sustainable. So if you don't like this result, what you can do is reopen the connection, make a fenestration. And this is now a theoretical exercise. You can imagine that if you make the fenestration from 0 to completely open, which means completely undo the fontaine operation, what will you see? Well, output, if you open completely the fontaine fenestration for the ventricle, it will normalize. The same thing in the bad fontaine. So that would be very, very good for cardiac output. What will happen with venous congestion? Well, the venous congestion will significantly decrease. So again, a very good thing. However, what will happen with saturation? Well, saturation will come down to levels which are completely non-viable. And so the thing we have to realize is these three components, we have to find a viable compromise in our patients. Somebody with a normal biventricular circulation, we don't need that compromise. We, with a normal biventricular circulation, we can go for full saturation, full output, and no congestion. That's our standard feature. A patient with a fontaine circulation, he must choose. Either he will go for good saturation, or he will go for good output and only moderate congestion. And the relationship between those is the degree of impedance or resistance in the NIñO portal system. So that means if we see the key features of Fontan failure, key features being low output and congestion, who is responsible or what is responsible for the low output? Well, it's very clear. It's the portal's connection. Because if you don't like it, take it down and you get your output again. The same thing can be said for congestion. If you don't like the congestion, take down the Fontan connection. Now, most of you are cardiologists. And so your key question will be, what is the position of the heart in this circulation? Well, the main feature of the heart is going to be that it has to keep left atrial pressure as low as possible, because that will enhance flow to go through the lungs. However, you have to realize that by going from the shunted ventricle to the Fontan ventricle, you are depriving, you are taking already away a lot of preload of that ventricle. So the ventricle is deprived not only for its body surface area, but don't forget the ventricle is overgrown by the time he will reach the Fontan state. So that means that the heart is severely deprived. And in that situation, we then are asking to keep left atrial pressure as low as possible. So can the ventricle neutralize the detrimental effect of this Fontan connection? The answer is very clearly no. There is no way the ventricle can do that. We all know that a ventricle cannot create suction. The ventricle cannot create a negative pressure which would be required to neutralize the effect of the Fontan connection. Can the ventricle aggravate the poor condition of a Fontan circulation? Yes, the ventricle can do that. If for any reason this end diastolic pressure goes up, obviously all these pressures will go up as well. So the ventricle can aggravate it, both acute and chronic. I'll come back to that in a second. Having said all this, it now becomes then very interesting to see what is the relationship in a Fontan patient between cardiac output, contractility, and pulmonary vascular resistance. Now, if we look for that in a normal circulation, here a normal person, biventricular heart, normal contractility. As contractility goes down, the output remains for a long time very stable. And it's only when you get to really dysfunctional ventricles that the output will start going down. What for Fontan patients? Well, the best Fontan patient with the lowest pulmonary vascular resistance and even a perfect ventricle, he will have decreased output. As contractility will go down, there will not be a significant decrease in output, except when you really come down to bad levels. And that is the same thing as pulmonary vascular resistance increases, output will come down, and again, it will only decrease at bad levels. So that means for a patient with moderate dysfunction, if you increase output, will he pump more? No. The main thing you have to do is decrease pulmonary vascular resistance. That will definitely alter the output in a patient. The same thing, but if you looked at another way, relationship between output, contractility, and pulmonary vascular resistance. As pulmonary vascular resistance increases in a normal person, even up to 5 units, cardiac output will not decrease. Why? Because a normal person has a right ventricle, and the right ventricle will squeeze a little bit harder. So a normal biventricular circulation will not be hampered by this. However, our best Fontan, as soon as pulmonary vascular resistance increases, cardiac output goes down, even with a perfect ventricle. The same thing if you have a moderate ventricle, and if you have a bad ventricle, I mean, if it's bad, always at high resistance, you will be a bad Fontan. But even if you decrease pulmonary vascular resistance, output in patients with a bad ventricle will remain bad. Here the same story. If you want to increase cardiac output in these patients, decreasing pulmonary vascular resistance will be much more efficient than increasing contractility. Having said all this, it becomes very important then to know what happens to pulmonary vascular resistance throughout life, because all our patients get older and we have to realize, is there a deadline? I mean, is there a border that they will not be able to transgress? In other words, will they all drop dead at the age of 40 or 50, something like that? Well, what do we know from normals? Normal people will have a low pulmonary vascular resistance for several years, and only at older age pulmonary vascular resistance will slowly go up. What do we know about our best fontaines? Well, our best fontaines by definition have a low pulmonary vascular resistance, and I think most centers now have patients in their 40s and 50s. We know that the good fontaines remain good for a long time. However, we know that one day this resistance will go up, and we still don't know what's going to happen then. This part of the history of a fontaine still needs to be written. What we do know is that fontaines with moderately elevated pulmonary vascular resistance, they have a decreasing result clinically, as they have an increasing pulmonary vascular resistance, and indeed you see that some of those fontaine patients in their second or third decade will go into significant failure. And what do we know about our worst fontaine patients? Well, patients with a high pulmonary vascular resistance, they may survive the fontaine operation, but we know that within months, at most within years, they will go into failure, and these patients will die prematurely. These patients probably never should have been offered a fontaine circulation in the first place. Can we change this with medication? We don't know. That's one of the research questions that we're asking. But another key feature for a fontaine circulation is what happens with end diastolic pressure. This is part of the PV loop of a normal ventricle. As it fills, the pressure will slowly go up. We know that the single ventricle during fetal life and early after birth will be volume overloaded. So typically you will see a change like this where end diastolic pressures will go up. But as the ventricle adapts for this situation, this is the typical situation for a chronic volume overloaded ventricle, which has adapted to its situation. If it takes too long, if this volume load takes too long, well, the ventricle will stiffen up, and that's the last thing we want to see. But if you unload the ventricle, typically what you will be doing at the time of fontaine circulation, this will now be the PV loop. This is reasonable, but what do we know from a ventricle which is chronically unloaded, which is chronically deprived? We know that end diastolic pressures will go up. And as I previously said, this is the worst scenario you can imagine. You don't want to see this. Can we alter this with medication? Again, we don't know. At this very moment, we don't have a drug that can alter significantly the evolution of end diastolic pressure. I'll jump through these. So the key thing that we have to do is have a nice connection, no gradient, and all these conditions should be met. Or in the lungs, keep the resistance as low as possible. And that means avoid hypoplasia, avoid pulmonary vascular disease, no stenosis, avoid collateral flow, and vasoconstriction. Any circulation in low output will go into vasoconstriction. What are clinical things that we can do? Well, we can optimize the fontaine connection if necessary. We can reconvert. We can dilate, stent away stenosis. We can do something about the pulmonary veins if that is a problem. And a lot has been said lately about pulmonary vasodilators, whether it be oxygen, NO, or any of these drugs. What do we know with all these things? Yes, they will improve pulmonary vascular resistance and they will increase somewhat the output. However, to levels which are still not very interesting or appealing for most patients. So in the failing fontaine, what was the job again for the heart? Well, keep the left atrial pressure as low as possible. Remain very compliant and keep suction as good as possible for as much that the ventricle can do it. We all do know, however, that the ventricle in a fontaine is big, thick, and dysfunctional. And there's many ways we can study that. That's what we are trained for. That's what we have the equipment for. And there is many reasons why such a ventricle will be dysfunctional, either because the malformation itself, the palliative procedures, the deprivation, the chronic low flow, and getting older by itself. One very important question is also, when we look at the ventricle, I always hear the word, the ventricle in a Fontan circulation is dilated. A question we should ask ourselves, is this an appropriate word? Because if you look at the history of such a Fontan circulation, look at this as the normal PV loop of a normal ventricle. As I said, and which is common sense, during fetal life, this is the PV loop during fetal life of a single ventricle. This ventricle has to do the same work as in another heart, the right and the left ventricle will do together. So by definition already, it will be bigger at birth. Immediately after birth, we give it a shunt. So the volume load will even increase the volumes in the ventricle. And this is now the PV loop of a ventricle prior to the glen. With the operation, with the glen and the Fontan, we will unload the Fontan operation, the Fontan ventricle. And if for whatever reason the output is low, this will be the PV loop of the single ventricle in a failing Fontan. And the key question now is, this ventricle over here, do you call this dilated? And that means if you compare it from normal to this, yes, you would say it is big. Or if you say, no, I know the history of this ventricle, is it collapsed? Because this ventricle came from this over here, coming down to here. You will say, well, is this again another discussion about semantics in congenital heart disease? We don't like that. Well, the semantics here is very important, because if you call this a dilated ventricle, that means that, like in congestive heart disease, you want to decrease the preload, you want to decrease the afterload, you want to increase contractility, the typical features that you would be doing in congestive heart failure. However, if you call this a collapsed ventricle, then you know that you want to increase the preload to the ventricle, which is a key feature in the Fontan. Afterload reduction may be very detrimental, and the contractility in these patients is a logic consequence of what we call of this Frank-Starling equation. So when you assess a ventricle in a Fontan, you have to realize that that ventricle has evolved from stretched and overgrown, stretched and overloaded while it was shunted, to overgrown and unloaded and underloaded at the stage of Fontan circulation. And what is typical for the Fontan is that we are now looking at a chronically deprived ventricle. With key features, it was previously overloaded and currently unloaded and deprived. How do I get there? Well, during fetal life, the growth of that ventricle is definitely much more than you would expect for BSA. And during initial palliation, the volume load will induce more growth, stretch, and dilation, more than you would expect for body surface area. So at the end of the initial palliation, the ventricle will be big, thick, and overgrown, potentially damaged. Then you go for Fontan, and you see acutely that it will shrink, it will collapse, contractility will decrease, and the chronic state of deprivation will make the ventricular and diastolic pressures increase, which means that the ventricle will remain big and thick, but with additional dysfunction. Allow me to jump this. So how should we manage this? The best way to avoid the best way to manage Fontan failure is avoid it. We should prevent pulmonary vascular hypoplasia. We should avoid distortion, pulmonary vascular disease. We should prevent excessive ventricular overload. At the time of surgery, we must prevent energy losses. And if the patient becomes symptomatic, if congestion is the problem, okay, you can give diuretics, but that will not cure the patient. If you want to increase output, you will have to decrease pulmonary vascular resistance. And indeed, we have some drugs nowadays But most drugs, if anything, they will decrease pulmonary vascular resistance 5 or 10%. That's not what we need. We need drugs that can decrease pulmonary vascular resistance 50%, 70%, something like that. Also, we want to decrease left atrial pressure. But as I said, we don't have a drug right now. We don't have a technique that can decrease left atrial pressure in a ventricle which is already significantly deprived. If all fails, we can bypass the fontan and fenestrate, or if really all fails, we can replace everything. So how should you manage these patients? Well, by being as nice as possible and as efficient as possible for the lung pulmonary vasculature. Here, you see, we all know that lung vessels will grow in relationship to the flow they get. And this is the normal flow of lungs throughout life. In fetal life, little flow, and then as of birth, they will get 100% of normal. What happens in a patient with a single ventricle? Well, during fetal life, there will be little flow, then they will get a shunt, and temporarily there will be an overflow. These patients will outgrow their shunt, so proportionally the flow will decrease to the lungs up to the time where we do the Glenn. By doing the Glenn, we significantly decrease the flow to the lungs. That means also the stimulus for the lungs to grow. We then allow the patient to outgrow slowly his Glenn shunt, and at the age of 3 years do the fontan. By doing that, we increase the flow to the lungs again, and then we hope that this level will remain like this. However, if you have a bad fontan, if something goes wrong with the lungs, this will be the pulmonary flow in a failing single ventricle system with minimal or inefficient or inadequate pulmonary overflow, which will result in inadequate growth. This means that the patient will become blue way too early. If then you go to a Glenn, he will be very blue, and by the time you go to a fontan, it will be a bad fontan with bad output and a decreasing result in time. In other words, this bad result over here of the fontan was created by a poor procedure over there. That's what we have to realize. And sometimes this may mean that when you reach this point over here, where the patient becomes too blue with too little flow to the lungs, you may want to go, instead of immediately go to a Glenn, go for additional flow to the lungs. That doesn't mean a second shunt. Sometimes you can go for a dilatable band like over here and increase the flow to the lungs, or something that we have been doing more and more recently now is expand the Blalock-Taussig shunt or whatever central shunt. Most of these shunts with coronary stents can be expanded so that you can increase the flow and get a better growth of the pulmonary vasculature. Here you can see that a 3.5 Gore-Tex shunt, you easily can stretch it up to 4.5, or a 4 shunt, you can easily stretch it up to 5.5 millimeters with significant increase of flow. Final slides. What are the take-home messages? The limits of the fontan circulation, like output, decreased output and congestion, do lie primarily in the neoportal system. The ventricle cannot compensate for this problem. It can aggravate it, but not compensate for it. For an ideal fontan circuit, you need the lungs to be as good as possible. Some mild dysfunction of a ventricle is not a disaster, but the lungs must be very, very good. And when you assess a fontan ventricle, you must realize that it has a history. It has evolved from stretched and overloaded during fetal life and initial palliation to overgrown and deprived at the time of fontan. Very important is the choice of your surgeon. It's obvious that when the patient is being offered his Glenn shunt or his fontan operation, that you need a good surgeon. However, the first palliation is the most difficult one, and for that you need the very best surgeon. It is actually this surgeon that will decide on how good the fontan will function. There is still a volume paradox. That means that the ideal volume load in the initial palliation has not been determined yet. We don't want to give too much volume because it's bad for the ventricle, but we don't want to give too little for the lungs because then they don't grow. And probably a mild volume overload in the initial phase is the better thing to do. Consider augmentable pulmonary artery flow when you go to a glen and you are not satisfied with the growth of the pulmonary vasculature. And do realize that the Fontan operation after completion runs on autopilot, which means once it's made, there's not too much you can do about it anymore. It allows very little modulation. We're trying now with the drugs like bosentan and things like that to modulate it a little bit, but don't expect spectacular results. And the best management of failure is like any procedure we do in medicine. The better way to, it's better to stay out of trouble than to get out of trouble. I thank you for your attention. Are there any questions?
Do you think that in the phase of the glen, it is better to get a pulmonary artery and not a glen only? A pulsated pulmonary.
So it's the question is, if you go to a glen, is it beneficial to have an additional flow to the lungs? The answer is, if the patient can tolerate it, probably yes. It will be beneficial for the growth of the lungs. But sometimes, if you go to a glen too early, it may mean that there is too much flow or there is too much congestion, and so that the head will be blown off by doing such a procedure. So that means if you foresee that you will leave additional flow, indeed it may be wiser to postpone a little bit the glen shunt, allow the pulmonary flow to decrease, and then do the glen, leave the additional flow, and then have optimal growth of the pulmonary vasculature. Then go too early to a glen shunt, and then have central venous pressures of 20, which are not nice to tolerate, which then will necessitate you to take down the additional flow. So I think if the system works, if it were my child, yes, I would prefer additional flow at the condition that he will tolerate it. And that means most likely you will have to postpone the glen shunt a little bit so you can allow it to stay. Otherwise, take down the additional flow and go for a glen only. So if there is a component of too much flow overflow, then it might be better to take down the pulmonary stenosis or the pulmonary trunk and go for a single glen, because too much is too much, too little is too little. I mean, it must be balanced, and we still don't know exactly. I think it's an individual, for every patient you have to make that decision.
And if the system, the pulsated glen functions, do you think that because some person says that it is better a pulsated glen that go well than a Fontan circulation?
You mean if you can choose between a glen with additional flow and go to full Fontan, right? In Paris, that was their standard strategy up to 10 years ago. So they would try to avoid to go to a full Fontan, and they would choose to go for a glen together with additional flow. What did they see? That their mortality was very low. Probably their patients would live longer, yeah. But once they got into adolescence, they all were blue, and their quality of life was very bad. So here comes then the key question: do you go for quality or do you go for quantity? In the Paris experience, almost all of their patients were converted to TCPC for the simple reason that the quality of life was too bad. Yeah. So, but they left most of their patients on a fenestrated fontan. So less congestion, more output, no perfect saturation. But we're not going to make athletes out of these patients in any way. So in theory, you're right. Leaving the hepatic veins, the liver at low pressure, if you can do it, perfect. But it is extremely exceptional that you will have a nicely balanced patient. They almost all will go to fontan. So allow me to extrapolate your question. Should we close a fenestration in every fontan? I must say that I have closed quite a few fenestrations in fontans, and the parents always come and tell me the child is better, can do more, and they even say it's happier. I mean, being blue is not that funny, yeah. So, but again, here comes the question: do we go for quality or do we go for quantity? I'm sure if you leave the fenestration open, they will live longer, but not as good. Your choice.
And when you decide to close a fenestration, what is the limit of the pressure of the pulmonary system that you take to close?
Frequently, I will know in advance whether I will close the fenestration, yes or no. So which fenestration will I close? If the surgery is being done and the patient dries up very fast, no chylothorax, he's very well mobile, and he has a saturation of 88, 89, everything is fine, you know in advance, you can close that. Yeah. However, the other patient, where he's operated, he has pleural effusions for 3 weeks, he has a chylothorax, you need to maintain the diuretics for 6 months, or otherwise he has a blown up face. Yeah, you know in advance you're not going to close this fence. I even don't bother taking him into the cath lab. So I only will take a patient to the cath lab if he's good, if he's free of diuretics, yeah, and that the system works well. If I am in doubt, but I must say I didn't do the testing for the last 4 or 5 years, yeah. If I am in doubt, I would not accept an increase above 16 or 17 millimeters of mercury. I would leave it open. But typically, as I take the patient, I do not make the decision in the cath lab. I know in advance, this is a good patient, I will close it. And if it's not a good patient, I leave it open. I even don't take him to the cath lab.
We have had some patients with a deprived ventricle. And we have been thinking about to close the fenestration with a cover stent and not with the device. Because if you in the future have to make a new fenestration, it is easier. Do you think it's right?
In my next talk, I will show you a few indeed fenestrations you can close with a covered stent. If I have to if I have to make a new fenestration, typically I will not go through the Gore-Tex. I will go at the proximal anastomosis, go through the inferior caval vein, which is infra thoracic. So go through the pericardium into the left atrium. And that you almost always can do. Gore-Tex is very stiff, it's very difficult to make a hole in there. So if I will go through the atrial wall itself instead of the Gore-Tex. So if I want to close the fenestration, typically now I use a PDA2 occluder for that, because it's very soft and small and it does the job perfectly, and it is not bulky. Yeah. If, however, I already start thinking I might want to reopen this fenestration one day, if I just make that thought, I will not close the fenestration. I mean, it's not worth it. If you have seen a patient with PLE, if you have seen a patient with plastic bronchitis, if you have watched them die, you say yourself, never ever again. If you can avoid it, I leave them blue.
Mark, we had a patient, female, 18 or 19, 8 or 9 years old, that when finished the procedure, the surgery, it was a Fontan fenestration with the lateral tunnel. The fenestration had 10 millimeters of diameter.
10.
10. Yes. Big.
Big.
Obviously, the patient finished the procedure. The day after surgery, the systemic saturation was 60%, and 48 hours after surgery, we did the procedure in the catheterism. We closed the ASD transient with a mini T-shack to measure the resistance, pulmonary resistance. Was low. The pressure of the pulmonary artery was 18 millimeters of water, no mercury. So we decided to close the ASD, and in that moment we used the cardiac device, the new cardiac device for fenestration, and we introduced a sheath, we perforated the cardiac device with a sheath 6 Frenches. The patient finished the procedure with the saturation was 90%. After procedure, 7 days after procedure, the patient was discharged. I want to know your opinion about this.
I must say that a 10 millimeter fenestration is huge. Yeah. So typically we will go for a 4.5 or a 5 millimeter fenestration. If, however, you do it on a high risk patient, and I mean, we should try to avoid it, but then I prefer to make 2 fenestrations so that you can easily close one and still have the other one open. Yeah. Mm-hmm. What you describe is partial closure of a fenestration, and I think the cardio device, I think it's no longer available, but I also enjoyed that device very much because indeed you could cut away completely one umbrella, only leave the legs, and from the other umbrella you could cut one square, half, 3/4, everything, yeah, and just leave the skeleton in the fenestration to reduce the flow. Yeah. So that's what we did 5 or 10 years ago. Nowadays, if we want to go for a big fenestration, then I prefer 2 fenestrations. Typically we always use the extracardiac conduit. The surgeon, he will make a big opening in the atrium and he will suture it very wide around the cortex, and then he will puncture 2 holes which are at least 1 centimeter apart so that you can close them separately with a device each. That would be my preference nowadays. I also did it with the cardio device, but we don't have an umbrella type of device anymore. I mean, there is none available anymore. So in the old days it was feasible. Now we choose for 2 fenestrations.
Mark, I think that Jesus make a reference to the new ASD closure device of Cardia, not the classic fenestration device. It's true. So at the difference, you don't have it's a more friendly device for make a fenestration in it. Yeah. You don't need to cut something. You just do a hole as you do a hole in a Amplatzer device, and you can left fenestration the diameter you like. The old one is not in use anymore.
Yeah. I must say I haven't seen the cardio has disappeared a little bit of the European market. I haven't seen their latest device.
It has been replaced with the ASD device.
No, my question was not about the device, sincerely. It was about the other.
But I would say consider
Yeah.
consider making 2 or even 3. So nowadays, now that in Europe the borders have come open, we do see some patients from former Eastern Europe, which were managed not the way we would have done it. So you do get patients nowadays, 16 years old, not the ideal Fontaine patient. And there, I must say that so the most we have done so far is 2 fenestrations. That already makes them blue. I mean, they come off bypass with a saturation of 70, but they survive. Their heart, their system can get adapted to the system a few weeks. And before they go home, we close 1 fenestration so that they have a saturation around 80, 85 when they go home. And then in the following months, as everything adapts and regresses, then you see what you do. But in most, we leave a fenestration open then.
In those patients that has pulmonary AV fistulas and that has the hepatic veins included in the system, how do you deal with it? Do you try to redirect the flow with stents, or do you send patients to surgery?
In a standard TCPC, the way my surgeon makes the connection, there is always some overflow from the conduit, inferior vein conduit, to both lungs. Typically, predominantly to the left lung, but there is some collision. So he never makes a complete offset. He just makes sure that there is some collision. And in that circumstance, I must say that I have not seen AV fistula develop. So apparently with that strategy it works well. On the other hand, we have had a few Kawashimas, and in those, nearly all of them, within 5 or 10 years after the Kawashima, you see AV fistula. So nowadays we don't wait for the fistula to develop. In infancy we will make the Kawashima, and then a couple of years later we will reroute the hepatic veins to the system, to the lungs, and then make sure it can spread to both. Your question then on if you have a TCPC with so much preferential flow that your IVC really goes to one lung, I think you have to judge that from individual case to individual case. It must be very exceptional, but I know these cases do exist, and indeed sometimes you can get away with making preferential flow, doing something with stents, ask the surgeon to remake his connection, sometimes make a little AV connection, a little blade octave shunt or a little axillary shunt to the left. Typically it will be the left lung that's in problem, to that lung, just to get the so-called whatever hepatic factor to that lung. So there's different options, but again the better thing is avoidance. I mean, the key in good Fontaine physiology, the key in good Fontaine medicine is avoid problems, because we are very bad in curing it. Any more questions?
Before Fontaine operation, in a patient with collateral vessels, venous vessels, yes, do you prefer to embolize the venous before to increase the saturation, or you send the patient directly to surgery? Because sincerely, I had a patient with this problem, and the surgeon preferred to embolize the venous. It was a discussion between us. Yes.
Conceptually, a big collateral going to your pulmonary arteries after the fontan is not beneficial, and theoretically you want to get rid of it. Yeah. And if I see during the pre-fontan evaluation, but that already means you do a cath. If I see during the pre-fontan evaluation that there is big collaterals, and my definition of a big collateral is typically I will do an aortogram under subtraction, and if I see significant flow on the pulmonary veins, I go and look for the collateral and close it. Yeah, and yes, I close it because the fontan probably will work better. Now the literature on that subject is not very conclusive. Yeah. The problem, however, with that literature is that nowadays, if you want to get something published in the literature, you must come with big series. Yeah. If you come with a series of 5 patients, they send you home and say, too small. However, those 5 patients, you may prove that it works. In order to get something published, and the Boston group with Jim Locke tried to do that, they included everything and everybody that they could call embolize anything. Yeah. And so they diluted their data so much that at the end of the story, they came with the conclusion, apparently it doesn't work. I mean, there is no advantage in closing these collaterals. But they have been closing collaterals that probably you couldn't enter with your catheter. Yeah. So the question should be asked, were they doing the good thing? I've seen some patients after fontan who were not very good. I closed the collaterals and they were better. So I believe that closing big collaterals is beneficial. Before the fontan, those collaterals will improve the cyanosis. So I only would close them just before the fontan operation, not 6 months before, but a week, 2 weeks, 3 weeks before the operation, close the collaterals, because otherwise you have to do it after the fontan anyway. And I believe, but again it's a belief, that their post-operative care probably will be better and smoother and less congestion and less pleural effusions. But if you ask me, do I have proof? No, and nobody has. But it feels good.
Marc, I think that the question of Jesus was about this last issue, the venous collaterals pre-fontan operation.
The veno-venous collaterals.
Veno-venous.
Yeah, you have to close those because otherwise you're blue. Sorry, I thought it was the arterial collaterals.
No, veno-venous. In our conduct is always close the veno-venous collaterals only if they are venous to pulmonary venous collaterals, not venous systemic, because you have to do the fontan in that
way, right?
Okay.
Because otherwise the veno collaterals, I mean, to the pulmonary veins will act like a fenestration, and at the end of the day you don't know how many fenestrations you have left. Yeah. So indeed, the thing is also the fact that they do make collaterals from systemic veins to pulmonary veins is not very good. Huh? I mean, it already suggests something is wrong. Yeah. So and if you, but typically that will be the Glenn patient. A typical Glenn at the age of 3 years will have a saturation of 80, 85, something like that. So if they're well below 80, you know there's a problem. Yeah. And indeed, closing those collaterals will be an option. But I don't like to hear that because it means there is a problem.
This patient had a very big collateral vein, no? Yep. So the surgeon sent us to close the collateral because he preferred to do the spontaneous operation with a better systemic saturation. Yes, this is the reason. Okay.
And he can, I mean, with his, if he leaves the fenestration, the saturation is much more controllable. Yeah. If it's a collateral, God knows what the collateral will do. It can expand and you become more blue, and it's not a very comfortable situation.
Yes.
Any more questions? Any questions at the remote sites?
Use coils for embolization?
Embolization of what? Of the arterial collaterals. Yes. I don't like particles because you don't know where they will end up, and they may end up in the lung parenchyma, and you don't want to have that. So typically, yes, I will use coils, but I make every effort to put my coil as distal as possible. I've encountered a few situations where patients had collaterals. They had been embolized proximally, so that means the distal vessels were still open, and then those patients present with hemoptyoi. Yeah, I mean, it's like your fingers are cut off. Yeah, they bleed, and it's very, very annoying to treat those patients. So again, avoidance. If you have collaterals you want to embolize, typically the mammary artery, for instance, yeah, don't coil embolize it proximal, but go with a catheter all the way down, and then put typically I will put big cook coils all the way up and embolize everything. Because if you coil embolize the entry, I mean, they will have collateral, the vessel will remain open, they may make bleeders, yeah, and present 10 years later with bronchial bleeding, which you cannot control. I mean, you cannot reach the vessel anymore.